All right, let's get right into it. Today we're tackling a true medical emergency, one where every second counts: acute respiratory acidosis. We're going to break this down so you understand it inside and out, because getting this right and getting it right fast can absolutely save someone's life.
Okay, so picture this. You walk into a patient's room and it's immediately clear something is very wrong. They're confused, agitated, and they are fighting for every single breath. The alarm bells in your head should be going off like crazy. The clock is ticking. What's the one diagnosis you have to get on top of right now?
So let's nail down what this emergency actually is. What are we really talking about when we say acute respiratory acidosis?
At its core, it all boils down to one simple, terrifying problem. Ventilation has suddenly failed. For whatever reason, the patient just can't breathe effectively enough to blow off carbon dioxide. And when that CO2 gets trapped and starts to build up, the body's entire chemistry goes completely haywire.
You know, the chemistry behind this is actually pretty straightforward, but its effects are devastating. As the CO2 level skyrockets in the blood, it mixes with water and forms carbonic acid. More acid means the blood's pH just plummets. That's acidemia, and that is the biochemical catastrophe that drives this whole emergency. So how do we prove it? Well, you're going to need an ABG and arterial blood gas. And the classic findings are right here. Your PCO2, the carbon dioxide, is going to be high, way over 45. Your pH, it's in the basement, less than 7.30. But here's the kicker. Look at the bicarbonate, the HCO3-. It's going to look pretty much normal. Why? Because this thing hit like a lightning bolt. It's acute. The kidneys, which would normally try to fix this, haven't even had a chance to wake up and start compensating.
Okay, enough with the labs for a second. Let's get back to the patient. What are you actually going to see at the bedside? What are those key signs that should make you think this could be it?
This patient is not doing well, and it is obvious. They are fighting for air, maybe breathing super fast but getting nowhere, or taking these huge, labored breaths. And that high CO2, it's like a poison to the brain. That's why they're confused, agitated, maybe complaining of a splitting headache. Let it go on, and you're looking at coma or even seizures. And when you put your stethoscope on their chest, you might hear some wheezing, or maybe something even scarier, almost total silence.
Okay, if you remember nothing else from this section, burn this into your brain. A sudden change in your patient's mental status, plus any kind of trouble breathing, bam, your mind has to immediately go to acute respiratory acidosis. It is a life-saving clinical shortcut. For real.
Right, so we know the ABG is our gold standard. But just seeing the high CO2 and low pH isn't quite enough. To really be a pro, you need to know, is this a pure, straightforward problem? Or is there something else going on too?
And to figure that out, there's a fantastic little rule of thumb. Seriously, this is one of those high-yield formulas you absolutely have to know for your exams and for your practice. This is the kind of thing that shows you really know your stuff.
So here's the magic. You want to know what the bicarbonate should be in this situation? You start with a baseline of 24. Then for every single point your PCO2 is above 40, you add 0.1 to that 24. It's that simple. Then you look at your patient's actual bicarb from the lab. If it's close to what you just calculated, usually within 4 points, bingo, you've got a pure acute respiratory acidosis. But if it's way off, you've got a more complicated, mixed-up mess on your hands.
All right, diagnosis is locked in. Now for the million-dollar question. Why is this happening? What is causing this disaster? Let's play detective and run through the usual suspects.
I like to put these causes into a few big buckets. First up, airway problems. I'm talking about a physical blockage. Think a nasty asthma attack, clamping the airways shut, a chunk of food, or a huge mucus plug. The next bucket, circulation catastrophes. Stuff like a cardiac arrest or a massive pulmonary embolism. Here, the lungs might be trying to work, but no blood is getting to them to drop off the CO2. The gas exchange just isn't happening.
Okay, listen up, because this is a huge, super important trap you cannot fall into. In a low-flow state, like cardiac arrest, your arterial blood gas can lie to you. It might show a low PCO2, and you think, oh, it's an alkalosis. No, that's what we call a pseudorespiratory alkalosis. It's fake. It's only low because no CO2-loaded blood is even making it to your sampling needle. The body's tissues are actually drowning in acid. You have to ignore that false number and treat the severe acidosis that's really there.
Our next bucket of causes is the command and control center. Think about the brain. If something shuts down the brain's drive to breathe, like an opioid overdose, too many sedatives, or a bad head injury, then breathing just stops. Then there's the wiring and machinery, the nerves and the muscles. In conditions like Guillain-Barré or a myasthenic crisis, the signal to breathe can't get through, or the muscles are simply too weak to do the job.
And for our last bucket, think of the lungs as being stuck in a straitjacket. They just can't expand. This could be from a collapsed lung, a pneumothorax, or a flail chest after trauma. Or maybe the lungs themselves are just stiff as a board, like an ARDS. And, we have to be honest, sometimes we cause it. It's called iatrogenic. A ventilator is set up wrong, an anesthesia machine fails. It can happen, and you have to be vigilant.
Okay, enough diagnosing. It is time to act. Knowing the cause is great, but right now, all that matters is fixing the problem. We have to get this patient ventilating again, and fast. So what's the game plan?
Here are your immediate action steps, your checklist. Number 1, airway. You have to own the airway. That might just be a simple chin lift, or it might mean you're putting in a breathing tube. Number 2, bronchospasm. If they're wheezing, hit them with nebulizers to pop those airways open. 3, oxygen. Get them saturated. And number 4, and you're doing all this at the same time, you have to aggressively attack the underlying cause. All roads lead to one goal: restore ventilation.
Now, I know what you're thinking. The pH is low, why don't we just give some bicarb to fix it? Right? Wrong. Almost always that is the wrong move. Giving bicarb here is like putting a tiny band-aid on a massive wound. The problem is not a lack of bicarb, it's way too much CO2. Ventilation is the cure. The only time you even think about bicarb is if the pH is in the toilet. We're talking below 7.1, and you literally can't fix their breathing right this second. It is a last-ditch, temporary bridge, it is not the cure.
And look, the stakes could not be higher. This is a fork in the road. You act fast, you nail the diagnosis, you reverse the cause, your patient has an excellent shot at a great outcome. You hesitate, you miss something, you're delayed, you are looking at cardiac arrest, permanent brain damage, and death. It is that simple. Speed is everything.
So there you have it, the what, the why, and the how to fix it. The action plan seems straightforward, doesn't it? But when things are going crazy and the pressure is on, it is so easy to miss things. So I want to leave you with this to chew on. In the middle of all that chaos, with your patient crashing, which one of those causes we talked about do you think is the easiest to overlook? The one that could slip right by you in the heat of the moment?